My name is Nicholas Irura, a radiologist, anatomist, and a clinical scientist. This video is designed for 200 level medical students, allied medicals, anatomy students. The postgraduate students of physical physics, biomedical engineering, and the rest of them could benefit from this video as well. For us talking about the radiographic anatomy of the chest, we must have been familiar with gross anatomy of the chest or thorax. Our knowledge of gross anatomy will be able to make the understanding of the radiographic anatomy of the chest easier and simple. Before we start talking about that, we'll need to know how radiographs are made and the position on which we will usually describe the anatomy of the chest on radiograph. The positions which radiographs are made are usually PA, AP, lateral, and oblique. However, for the purpose of this video, we're going to concentrate on PA, which is most often than not that's been requested for. That is the posterior anterior radiograph, where the beam, X-ray beam, will come from the posterior part, that is the behind, and the cassette will be in the anterior by the chest. In another couple of minutes, we'll be able to see how the structures in gross anatomy, how they appear on radiograph in the chest. What we need to know first is that when you talk about radiograph, we'll usually refer to those images that are dark or white, that is lucent or opacity. So every other structure will have different shades of gray and could be closer to lucency or could be closer to opacity. And as we go on, we'll be able to appreciate that. Another thing we need to know with chest radiograph is that the chest radiograph, the right of the patient is the left of the person viewing the chest radiograph, whereas the left of the patient is the right of the person viewing the chest radiograph. That is to say, this is the right of the patient, and this is the left of the patient. Furthermore, in gross anatomy, we know the thorax is made up of bones, soft tissues, and it has a thoracic cavity. And within the thoracic cavity, there are organs. And these organs appear as either lucent or opacified, or in between. We have different grays. As we go on, we'll be able to appreciate that. When we look at this is the clavicle, which is appearing white, opacified. These are the bones. They are appearing white, opacified. Same thing with the heart. However, if you look at this, which represent the lungs, the lung fields, they are lucent. Okay, this simply shows that the lungs contains air, while these other structures shows they absorb radiation at different levels. But however, there's a true transmission of radiation in the lungs because it contains air. Nothing is stopping the radiation. Furthermore, we'll now count the ribs. And we are talking about 12 anterior ribs. 12 ribs that are paired, and you have both anterior and posterior ribs. So, however, on the chest radiograph, sometimes we can count them, they are visible, and sometimes all of them are not visible. But in this particular chest radiograph, we have 12 ribs that are visible. This is one, posterior ribs, second posterior rib, third, fourth, fifth, sixth, seventh, eighth, 9, 10, 11, 12. The 11th and the 12th ribs are the floating ribs. So on the anterior ribs, if we look at the left side of this radiograph, we have first anterior rib, second, third, fourth, fifth, sixth, and seventh. So what happens on chest X-ray for optimal chest radiograph, that is with good chest radiograph with good inspiration and good factors, you will have on the posterior you will have about 9. However, between 8 and 10 will be acceptable, whereas on the anterior ribs you see about 6, but between 5 and 6 and 7 could be acceptable as well. So if we go further, because we know the posterior part of the thorax is made up of thoracic vertebrae, and which are indicated here. These are thoracic vertebrae. They are opacified, and they are bones because they contain calcium. However, there are lucencies between the vertebrae, and those are disc spaces. They are intervertebral disc spaces because they don't contain any calcium, so they appear lucent, so they cannot absorb any much radiation. But one thing we notice is that the level of gray here is different from, or rather the level of lucency is different from the level of lucency in the lungs. And we have the spinous process right in the middle. So from the midline, we have the trachea. The trachea is the vertical lucency with opacity at the two ends, looking like, some people call it windpipe. And as you go further down, it divides into right main bronchus and left main bronchus. And this is done usually at the level of T4 or T5. The right main bronchus is short, is vertical, is wider, and steep, whereas the left main bronchus is narrow, is longer, and it's not. At the level of the division of the level of the bifurcation of the trachea is called the carina, and there's the Carina angle. The angle is usually between 40 to 80 degrees. So why is that important? It is important because the Carina has significance in terms of cardiac pathology. Usually, if the Carina angle is over 100, that may suggest that the left atrium is enlarged. And that could give a hint, especially in low resource area. Okay. If we go further, we have the lucency in the lungs or in the lung fields. And along with that, we have the hilum, left and right hilar regions. The hilum itself is formed by pulmonary vessels. And these pulmonary vessels, the upper and lower lobe pulmonary vessels, actually form the hilar angle or the hilar point. And if there is any obliteration of the hilum or the hilar angle, that may suggest further investigation. And usually what happens is that at the hilum, the lymph node, hilar lymph node is not seen. And the left hilum is usually higher than the right hilum. The opacity here, the seen is that of the shadow, the cardiac shadow. And it is divided into two parts by the midline. Okay, and you have the left part, which what form the left cardiac border as the left ventricle, whereas the right cardiac border is formed by the right atrium. And the right cardiac border or the right atrium is usually 1/3 of the cardiac shadow. So while the left ventricle is usually, or the left side of the heart is usually 2/3 of the whole of the cardiac shadow. More also, we have the cardiac diameter. The size of the cardiac diameter should be less than 50% of the thoracic diameter. Okay, and that is to say that cardiothoracic ratio should be less than 50%. If it is more than 50%, it's usually classified as cardiomegaly. This can only be said to have happened in a PA film, not in an AP film. In an AP film, there's what is called apparent cardiomegaly. So it cannot be used for measurement of the cardiac size, real cardiac size. Further, we have, because the left ventricle pumps blood through the aorta, okay, and there's on the left side we have the aortic knuckle, and that goes on to curve medially and further down to form the descending aorta or the thoracic aorta. There are other things that we can talk about in this chest radiograph are the cardiophrenic angles, the right and the left. This is where the heart and the diaphragm, where they meet. So on the right side, you have the right cardiophrenic angle, whereas on the left side, you have the left cardiophrenic angle. Also, the right hemidiaphragm and the left hemidiaphragm. The right hemidiaphragm is a little bit higher than the left hemidiaphragm. Why? Because the left hemidiaphragm, below the left hemidiaphragm, you have the right hemidiaphragm is a little bit higher than the left hemidiaphragm. Why? Because the right hemidiaphragm, below it, you have the lever, which pushes up that diaphragm on the right side. Whereas on the left diaphragm, below it, we have a lucency, which is usually called the gastric bubble. And if we go further, we have the costophrenic angle. And the costophrenic angle is made up of, is where the lung meets the rib or the chest wall, and it's usually very acute. It's about 30 degrees. That is the acuteness of the costophrenic angle, which is sharp, well defined on both sides. That is significant because if there's any fluid called pleural effusion or hemothorax, you have blood, you may have obliteration of this angle. And sometimes pleural thickening can cause blunting of these costophrenic angles. And as we go further, we need to talk about the soft tissues around the chest. And these soft tissues usually helps you to, gives you an idea if that person is a male or a female radiograph. In this particular case, because this indicates breast and it is a female chest radiograph. In summary, we have been able to identify some structures that we see in gross anatomy of the chest, and we are seeing in chest radiograph, such as the ribs, the bones, the heart, the lungs, and the soft tissues. So with this, I think I have been able to make anatomy of the chest X-ray simple. And by so doing, please don't forget to like, share, and subscribe. Also turn on your notification. If you have any question, you can drop it in the comment section. Thank you.